Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gollin.
Hey everyone, welcome to the Gastro Girl podcast. This episode is a really interesting one today. We are joined by the wonderful Jaime Ackerman. She's a physician assistant at Atlanta Gastro in Atlanta, Georgia. And we're going to be talking about how can I talk to my healthcare provider, my doctor, about my IBS-C? One of the biggest challenges we've seen from patients is they're embarrassed to talk about their symptoms. They feel like they don't know how to explain the symptoms, and they just want to be heard by their healthcare provider. So Jaime's here to tell us all about the best way to have these engaging conversations and really help build that rapport with our healthcare providers. Welcome, Jaime. So happy to have you on the show today.
Thank you. I'm so happy to be here.
Oh, great. So I'm sure you've worked with a lot of patients over your career. You're often the first person that we talk to in the office. When we go into the exam room, usually a PA will come in and ask us questions. So you're the perfect person to talk to about this today. So we've done other podcast episodes about IBS-C with more details about what it is and all of that. So this episode, we're going to particularly focus on how to have those conversations. So if you're not familiar with IBS-C, we encourage you to check out our playlist for more in-depth information. But just to get started, Jaime, can you just define what IBS-C is?
So basically, so if you're going to get abdominal pain or bloating with a change in your bowel movements where you're having a decreased complete spontaneous bowel movement within at least once a week within a 3-month period, a lot of times that's what's considered IBS-C. And it goes into, it used to be where people said, oh, it's a diagnosis of exclusion. So you have to rule out this, and this before you can say it's IBS-C. But that's not the case anymore, because if you don't present with any alarming factors like rectal bleeding or family history of colon cancer, colon polyps, Crohn's, colitis, concern for celiac disease, if you don't present with a lot of other issues other than just the constipation with some bloating and pain and no need to go forth and do the colonoscopy and everything else, then you can go ahead and say, you know what, this is probably IBS-C before putting them through a significant amount of tests necessary. So it has changed in that aspect where people are able to diagnose it quicker without doing so many added extra tests that aren't necessary on a patient. When if you think that's what it is, it probably is what it is.
Yeah. So if a patient came to your office and, they're not sure how do I start this conversation? I really haven't gone to the bathroom. I got this pain. I have this bloating. What is the best way for me if you came in the exam room and you said, okay, what's up? What is the best way to start this conversation with my doctor or my healthcare provider about my IBS-C symptoms?
I would say, listen, over the past however month, 3 months, 6 months, years, some patients, I feel like I've had significant constipation where my bowel movements I can't have a bowel movement without taking something, or have a very hard time having a bowel movement. You want to explain that if you have pain or bloating with it, I have pain, I have bloating. I always teach people because the first question I'm going to ask, and this is what I try to teach all the other students or providers I work with or train. The first question I'm going to ask somebody is, what is your normal bowel habit? When everything was great, or when everything is normal in your life, what was your normal bowel habit? Some will say, I've never had a normal bowel habit. Some will say, oh, my normal was one bowel movement every other day, but now then I said, then what is it now? So then I always have something to go back to compare it to, because if a patient comes in and says, if they're coming in for a follow-up and I'm like, how are you? And they're like, or if a doctor or someone says, I'm better, then they go right on to something else. But what does better mean? Like, you actually have to delve in and ask. And that's the only way that I'm able to differentiate between better and, completely resolved. My goal is not just to make someone better, a little better. I want them to feel where their quality of life has improved significantly and they're not coming in to complain about these symptoms anymore. So you want to be very specific about, and sometimes it's hard. It's hard to say, and this is the other thing. When it comes down to IBS-C and constipation, a patient can come in saying, I have 10 bowel movements a day. And that can still be constipation, because if you say, really, if you're having 10 bowel movements a day, well, every time I sit down to pee or I feel like I have an urgency, I pass a pebble. Well, if you're passing a pebble or a rabbit pellet or whatever people want to call it, Bristol stool scale number 1, 10 times a day, but you're never getting a complete spontaneous bowel movement, that right there is telling you that you have constipation. So constipation is different for every single person. So that's why you have to figure out, what is constipation to you? So you have to make sure that you are getting a history.
So that's a great point. And I think a lot of times when patients go to the doctor, they may have appointment scheduled for 3 months out. And in the immediacy of the moment, when they make that appointment, they may feel different when they actually have the appointment. So in order to have the right conversation, what is your suggestion for, keeping track of, how can they prepare for their office visit, and when should they start preparing?
Keep notes, keep a diary. Everyone has phones these days that you can, every time you have a bowel movement or every time you eat or every time you're having symptoms, make the notes, keep track of it. So when you come in, I know so many providers hate it when people come in, oh, I have a list or I have this, but it's actually important because we're all busy. We're going to forget things. You know what I mean? And then you're going to walk out and be like, oh man, I should have told them that. Keep track. Okay, well, I had a great bowel movement today, spontaneous, but then I haven't had another good bowel movement since, oh wait, it's been months. You can look back and see, or weeks. Then you also could put, like, what did you eat those days? Was anything different? Did you try new medications? Were you traveling? Did you have a procedure of some sort? So you can kind of see, was there a lot of stress? Were you was there more anxiety? Were you undergoing, a stressful event in your life? There's so many different causes that can, because it's a big brain gut interaction. So you have to look at that. I mean, think about it. 95% of our serotonin's in our gut and only 5%'s in our brain. So much of what we are doing, when they say your mind's in tune with your gut, it is. So keeping a diary in your phone is a really great way to walk in and be like, hey,
And even like exercise, maybe someone who used to exercise and they,
Exactly.
they were more sedentary. Maybe they were doing a big work project or family life got in the way and they weren't
Exactly.
exercising as much. Could that impact it? Something to keep track of?
Very much so. Or have you been put on semaglutide, one of the new medications that a lot of
That's a
people are
good point.
taking? The Ozempic, the Zinpep, Zepbound, the Wegovy, the Mounjaro, all the different medications slow people's guts down, whether they're on it for weight loss or diabetes. So you also want to make sure that you remember, have you started any different new medications or change in medications?
That's a great point. And I want to just stay here for a moment. Some of us may be embarrassed to tell the doctor that we're on that medication because we don't want to be labeled, oh, you're vain and you're doing this weight loss drug, you're lazy. Can you speak to that and why patients shouldn't be embarrassed to admit to their physician that they're on those medications? It's critical.
It is critical. I mean, it's not if the medication, first of all, we're in the medical profession, you should never be embarrassed to talk to us about anything, because as a medical provider, we should never judge. And if you judge, you shouldn't be a provider, because patients, everybody's lives are different. And there's no reason you should ever judge someone based on a medication. And if you do, then never see that provider again, is all I can say. People need it. Some people want this medication. Listen, if they have tried everything else in their life and they're not able to lose weight, if they're women in menopause that are, have extra weight and people are trying, if this is what their doctors prescribe them and they feel like this is what they want and they need, because feeling good about yourself can help so much from a mental and other standpoint. Also from a health standpoint, some people can be mildly insulin resistant and need it, yet they're not diabetic yet. Don't be ashamed to tell us what you're on, because also if we're going to go do a procedure on you and do all these tests and you didn't tell us that, it can harm you. Okay. So for now, we now have a whole thing where if you take these medications, you can't have you have to be off of it for a week prior to a procedure. Even phentermine, you have to be off things because it slows your gut down, meaning you could aspirate, meaning you could get pneumonia and other bad things during procedures. So these are things that we have to know, as well as so many of your symptoms could be fixed with something as simple as stopping that medicine or changing it before putting you through 1,000 tests, spending a ton of money. So you should never, ever feel embarrassed to talk to a provider about anything.
No, thank you for sharing that, because I really want our patients and our listeners to understand that, because a lot of times we may not realize that everything impacts our symptoms. And if we're not open with our providers, that could get lost and it could get missed, and that doesn't do anyone any good. So thank you for sharing that, Jaime. It's so important. What are your, sometimes some of us may have difficulties explaining our symptoms. Maybe you could share some advice on, what's the best way that we could share our IBS-C symptoms to our doctors, especially if they vary from day to day? Is there special lingo that we should use, or what's the best way?
You want to talk about your bloating? A lot of people will say they feel like they're 10 months pregnant, but bloating is pain. Is it cramping? Is it relieved with a bowel movement? So a lot of patients, a lot of ways we know IBS is a diagnosis is when patients say, oh, my abdominal pain or my bloating is relieved with my bowel movement. That's a good thing. Do you wake up bloated? I hope not. Usually these people get bloated throughout the day as the day goes on, especially if it's a woman and they wake up and they're bloated consistently. The bloating never changes. You got to rule out other things like ovarian cancer and stuff, because that's what, we have to understand. When are you bloated? Is it as worse as the day goes on? From a diet standpoint, have you tried a low FODMAP diet or something? Have you tried eliminating different foods? Did the bloating or pain differ with that? So when it comes down to explaining your symptoms, it's great to be able to come in and say, hey, I've tried this. I've tried cutting out this. I stopped dairy for a week or two and nothing changed. Or I stopped gluten, or I stopped eating broccoli and cabbage and legumes. Like, what have you tried, right? And then being able to, I think the Bristol stool scale is great. We have it in every room to be able to say, oh, my poop looks like this. Because a lot of times it's hard. I will tell you, the majority of my patients come in with pictures of their poop for us these days. It's really fun. But that's something that, as much as we don't really want to see it and it's kind of gross, but it helps. It's helpful. I mean, I'm not telling you to go take pictures of your poop, but be able to explain your poop. And we talk about poop all day, so don't be ashamed. Like, this is what we do. We talk about poop. I mean, a lot of the younger kids, like when a 21-year-old boy comes in to talk to me, he's embarrassed about talking about his poop. Like, it's what I do. And we don't think about it as that. Like, that's the thing. As a provider, I'm not thinking about, oh, I'm poop, diarrhea, yay. No, like, we're in our head coming up with looking at it as this is pathology to us. This is a way to explain it, where gives us a better way to diagnose you.
Yeah, it's like you're detectives. The more information, the more facts you have, the more things you can make the right diagnosis. And I love that part.
That's why I love GI. People are like, why do you like GI? I'm like, because it's one big puzzle and not a single patient is the same. I could see 10 patients with IBS-C and not one patient presents the same. 10 patients with reflux, not one patient presents the same. You're never getting the same stuff. So it's never boring. And I love puzzles. So I'm constantly getting to be a detective and come up with a way to help somebody, because the way I'm going to help you is not going to be the way I'm going to help the next person, most likely. Everybody's different. It's awesome. I love it.
I know. It's so interesting. I love even when you read about different cases and trying to figure out what it could be. I think it's fascinating. And you guys have a really important job. And on that note, let's, go back to the role of the patient in the office and what they can do, what else they can do to help their provider, like with frequency and severity. Like, how can a patient describe their frequency and then severity? Because, there's no baseline of okay, severe, or is there, how can they describe it so that you have an accurate picture of the severity of it? They may be so used to it that they may diminish the pain or diminish the severity. So how can we, help you get to the right answer for us to help us?
Well, it's hard because like you said, severity can be different for everybody. Mm-hmm. One severity for one person could be, oh, I have one bowel movement every 3 weeks. And you're just like, wait, what? Are you telling me nothing comes out of you at all? Or severity for them could be like the 10 bowel movements a day versus one full bowel movement a day. When you come to us, try to figure out a way to differentiate between what you had to what you have now. What was your normal then to now? And it's hard to say severe versus not, because every patient's different. And The consistency and frequency is a big thing. So I always say, is your frequency changed and has the consistency changed? So do you have again, is it more pebble-like hard, or are you having the loose watery stools? Is it more frequency? Is it one, like we talked about before, 1 a day, 10 times a day, to 1 a week to 3 weeks? So consistency and frequency are, I think, the biggest two ways to explain it. From a severity standpoint, I think everybody's different on how is it affecting each person's quality of life. And that's another thing. Explain that. Like, if you express to us how it affects your quality of life, I can't leave the house because I don't know when I'm going to go. But if I take something to go, then I definitely can't leave the house because I'm scared. I don't know when it's going to, hit me and I'm going to have to go. Or I'm so bloated, I feel so gross, I can't leave the house because I can't put on clothes and I'm nauseous and I don't want to eat when I go out because I feel like. You explain how it affects your quality of life, because that's a huge part of this.
Yeah, that's so important. And the other thing, that we all concerned about is our treatment options. The last several years there have been a lot of different treatment options for patients. So how do we talk about this, and how do we feel like we're an active participant, or
everyone sees these commercials all over the place, right?
Yeah. But how do you know what's right for you? And how do you ask the doctor, oh, I like this commercial and I like the song and I remember it. Can I try this? Or is it, is there something more, that we should be aware of as patients to be able to, ask for the right treatment? Or if the doctor suggests this, what kind of question should we be asking?
There's almost like it's not an algorithm that we go through. I mean, some people, they have one, but, I have my own way of thinking who I'm going to give what to. And a lot of it is based on man, woman, age, and how severe their constipation is and their symptoms. So it's incredible. We have all these drugs out now, right? I mean, you've got the GCC agonists, you got the Linzess and Trulance medications. Then you've got Ibsrela, which is a different mechanism of action, which is phenomenal. Then you've got, Amitiza. You've got lactulose, people do Miralax, Metamucil, Benefiber. So there's so many options, and it's really hard to pinpoint what to use until you see that patient. I have a specific reason for using each medication. Is it a little old lady who you don't want to go blowing out of the water by giving them, Linzess versus let them try, they've not tried Miralax or Benefiber, start low. Or is it a patient who comes in and says, I have one bowel movement every 3 weeks? Okay, well then, you know what? And I've tried this, and this over the counter, and I don't have bowel movements without Dulcolax. Well, yeah, you don't, because one, you're constipated, but two, those over the counter laxatives like Dulcolax and X-Lax make it where your gut's not going to work without it. So let's find something a little safer for you to take long term. And I give each of my patients samples of either Linzess, Trulance, and Ibsrela. And I have them try them. And I tell them, it may cause you a ton of diarrhea. That hopefully will get better. But if you can't leave the house, I need to know. And then, try this one for a week and a half, 2 weeks. Try this one. Tell me which works better. Then you've got something like Motegrity, which is an unbelievable drug for motility, but nobody can get these days because it's so expensive. And I think it just went generic too, but you still aren't able to get it. But it's the only medication from a motility standpoint. And that's the other thing. Is this constipation secondary to they're needing the more water into the stool, or is it secondary to a motility? Is it from older women or women in general having pelvic floor dysfunction secondary to having children or getting older? Or is this, there's so many different ways you have to look at it. And it's really important to go in there and you can ask the provider, do you feel that this is secondary to more motility, or do you think it's more this? We usually try to rule out the other before the motility, because that involves anal rectal manometries, defecographies, a lot of different testing that a lot of people don't want to do to get a true diagnosis. I usually just try treating anyways, a lot of the times. But I think you just have to, you can ask about the meds, but I would almost leave it up to the provider, and they should be willing to offer you different options, because everybody's different. And that's really hard to answer and saying,
Yeah. No, that's a fair answer because, I'm just coming from the patient's perspective, do we have, what should we ask for? But that's a great point. The other point I want to make, and I like your approach because you said, try this for how long. And patients, we get frustrated. We want to have instant results. We want to feel better like right away. And if it doesn't, we're like frustrated and we give up or, we never go back to the doctor again. So what is your advice for patients when you're giving them this option to try? How long should they try it for? And then when is it time to, maybe discuss the next option for them?
Well, they also have to remember IBS didn't happen overnight. So we can't find a treatment overnight. Some people it works, but not everybody. So you got to have a little bit of patience, which is hard because people are uncomfortable. I would say when I give samples, I give enough for about 12 days and 12 days, almost 2 weeks, just because that's how the sample count works out. Or I'll give them enough for, 15 days and 15 days. If you try one and after a week you don't have a bowel movement, it's not the right medicine. If you try one and you're having like water diarrhea that you cannot leave the house, it's not the right medicine. Stop it. Try the next one. Give it a couple days. Like they say in a lot of the studies that the diarrhea stops after a couple weeks and you get better. But I don't know about you. I'm not going to want to be, having such severe diarrhea that I can't leave the house for 3 weeks to see if it's going to work. I don't have that type of time. Nobody does. You know what I mean? So I also give samples first of things because 1, cost, 2, insurance, 3, like some of the great drugs out like lubiprostone, Amitiza. Great, but some people aren't going to get it approved until they've tried this and this. So I can then at least say, oh, I've had the patient try this. I've had them try this. They didn't do well with this. So it's easier to get things covered with the prior authorization standpoint. I usually give them a couple weeks, even though the studies say longer. I'm trying to be realistic.
Right. And it helps you figure out what the mechanism of action that the patient needs addressed, correct?
Exactly. Because if Linzess and Trulance don't work and then Ibsrela doesn't work, then I'm like, okay, this is probably more of a motility issue than anything. Because if neither of those are working or neither of those 3 are working or Amitiza, then this is more likely motility and we got to figure something else out.
Can you describe the difference between the first 2, Linzess and then Ibsrela?
Yes. Okay. So Linzess and Trulance, they're GCC agonists. Is a type of drug. Basically, they are called secretagogues. They work on, think of a slide, a water slide, okay, with holes in it, all right? Secretagogues, the water can come in to help with the pool and go out, in and out through those holes, okay? So they secrete in and out, and it pulls the water in and helps you go. Ibsrela we've now coined the name, or Darren Brenner did, called retainagogues. And what that means is, think of the slide, there's no holes. There's no holes for the water to seep in and out. It stays in the slide and just goes right through. So it's pulling the water in. It works on the sodium channel, like the NHE3 of the GI tract versus the GCC agonists do. They work differently. It's a completely different mechanism of action. They both work on having the water increase the water in the stool. So, water follows sodium. Ibsrela holds the sodium in. Water is going to follow and make it you go through. So they are different mechanism of actions. And that's why one may work for one and may not work for the other.
No, I think that's so interesting, and it's helpful to understand because I'm always fascinated by the mechanism of action of these drugs. And I think it's important for patients to understand that's why things may not work right away for some patients, or they may not work at all, because these drugs have different ways of working. They can still address the same condition or symptom, but they work differently. So it is about patience. I think you're right.
It is. And that's why you have to make sure you listen to the patients and you understand the drugs.
Now, in terms of monitoring the patients and our engagement, as a healthcare partnership, I like to think we're active participants in our care with our healthcare providers. How do you monitor your patients' progress, and what's our responsibility to let you know how we're doing?
Patient portals are incredible. I tell my patients to send me a message on the portal and let me know how you're doing. I check my portal messages constantly in between patients, checking it. I try not to leave work that day without making sure that I've answered my questions. Because if I'm a patient and I send a note to the provider, I want someone to respond to me. So I also give all my patients, they have the direct extension to my medical assistant or myself that they can call us if we need to. I'm not going to make every patient come back in 2 to 4 weeks and let me know how you're doing. We all work. We all have lives, whether you have children or not, or you work, you don't, it's hard to get in, and it's a copay and it costs money, and you don't need to come in once a month. That's not how I work. Like, you need to be able to, if they have a portal, amazing way to say, hey, this worked great for me. Can you send in a prescription? You know what? I tried both of these didn't work. What else can we try? Or what's the next step? And if it's something where we need you to come in, or we schedule a procedure or imaging, fine, we do that. But at first, I'd rather you just keep up with the provider.
No, thank you for that. And is it okay if patients ask questions about other lifestyle changes like diet? You talked about fiber, hydration, and diets, in addition to maybe the medication to help us with our
of course.
IBS-C. And
well, there's a lot of patients who don't want medicine.
Yeah.
They're like, I don't want medicine. I don't want to take anything. What can I do? I'm like, well, okay. If you had diabetes or high blood pressure, would you take medicine? Think of it like that. It's a disease. So sometimes you're going to need something. And I try to make them feel more comfortable about that. But, diet, yes, there's, some of the greatest diets for this. The low FODMAP diet is phenomenal. I used to be where I want you to do a strict low FODMAP for 2 weeks and then pick one thing at a time and slowly put it back in. It's really hard for people to do. Now you can, I give them a paper I have that says, okay, for the first, cut out the lactose, and the next time the fructans, and the next week the fructose, like the different parts that make up the FODMAP diet, and see what, works for them. Another great thing is peppermint oil. So IB Guard.
Oh, I love that. I've used that personally. I think it's very helpful.
It is very helpful. It's great. Peppermint oil is another thing that helps people more with the symptoms than not necessarily like the constipation as much as the bloating and the stuff and the pain that come along with it. People love the peppermint oil stuff. Fiber wise, I'm a huge proponent of Benefiber. I love Benefiber. Benefiber, one, it has no taste. I mean, look, I put it in my kids' water. They don't know. But it also doesn't cause the bloating and gas that like Metamucil. Metamucil is a great drug, one more for men than women. With women, it causes a ton of bloating and gas, but it also bulks your stool more. So for my patients who have like fecal leakage or urgency, or they have things that seep out, they don't feel like they're getting, they feel like they've pooped, but not everything. That's where medications like Metamucil are great, because it'll help bulk up the stool. Because that's what psyllium husk does. On the patients who've had part of their colon removed, psyllium husk is wonderful to help bulk up the stool. Other over-the-counter stuff, magnesium. Magnesium is a wonderful thing to take. It helps people relax. Magnesium Calm is fabulous at bedtime because it also helps you sleep and it's relaxing. That helps people poop if they want to do more natural stuff. Miralax obviously is a phenomenal drug, but there's people who take Miralax and literally every time they sit down to pee, they're pooping a little and it's messy and they're not as clean. Not the right drug for them. But the other thing, the problem with Miralax, it has the word lax in it. So people think it's a laxative, when I personally think of it as just like a really strong stool softener. It's safe. Babies take it. It's fine.
Yeah.
It's an easy one. So there are over-the-counter ways to better constipation without having to. Don't do colonics.
Oh God, we get so many questions about that. Tell us why.
Well, one, think of it. It's like a money-making thing. And if don't you think if it was a money-making thing and it worked, every doctor would be doing it to make money? Number one. Number two, it gets rid of all this good bacteria. So our colon has a ton of good bacteria. The bacteria is what makes our poop, right? If that bacteria is washed out, I got poop anyways. So it disrupts that. It can perforate you. People don't realize that it can perforate people. These are not doctors doing it. Your body is going to get rid of what it needs to get rid of. It is a very smart thing. Our body is smart. When people eat something wrong or they've got a stomach bug, what do? We vomit or have diarrhea. You're getting it out of your system. So I don't think it's necessary to, they're just not good for you. And I have had so many patients who have chronic medical conditions and chronic IBS and issues because they did colonics for so many years. It's rid their gut of any of the bacteria that's needed to keep yourself going. So don't do colonics. It's a waste of your money. You're not going to lose weight. You're not like the minute you eat again, you're gaining weight again. Like, come on.
Yeah. You know, and the evidence, right? Just straight evidence.
It is straight evidence. And
there's no science-backed reason to do it.
Nothing. No.
So thank you, because we get
Don't
that
do
all
it
the
just
time.
to go fit into a dress because you could hurt yourself.
No, thank you for that. For those listeners who are not under the care of a gastroenterologist or a PA who works in a gastroenterology practice, when is it appropriate to ask their primary care doctor for a referral to a gastroenterologist to help them manage their IBS-C?
Anytime. I mean, if you're miserable, if your quality of life, if it's been going on for 3 to 6 months and you're so miserable, if you have tried different over-the-counter things and nothing is working and it's affecting your quality of life, then you need some kind of treatment. Like, you need help, and that's what we're here for. And if we think it's an easy fix, great. If it's something that requires more, then you could be missing something too. This may not just be IBS-C. So you want to make sure that, look, we're finding colon cancer in 20 and 30 years olds left and right these days. So it's so sad. So if you have a concern for GI symptoms, make an appointment to see us. Let us take care of you. I mean, it's as easy as finding the right medications, and you could be living a great life.
Well, thank you. This has been such a great conversation, and I hope it was helpful for our listeners out there. Thank you again, Jaime. Hopefully we'll have you on again with another, some more good advice for our patients. You've been fantastic.
Thanks.
Thank you. And don't forget, listeners, subscribe to our podcast, share this episode and others with your friends and family. The more ratings and reviews we get risen up in the algorithm, and more people will be able to access these podcasts. They become more visible. So thank you so much.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.